Dr Pathria, and I will be giving a lecture for this meeting for Bangladesh for about stress fractures. I'm sorry that I was unable to attend in person. Just so you know a little bit more about me, I trained in Canada. I'm originally from India, and after I did my training in Canada, I went to San Diego and did a fellowship with Dr. Resnick in musculoskeletal imaging. My main interests are in MR and in trauma, and what I'd like to talk about in this session with you is stress injury of bone, and we'll talk about the clinical manifestations, imaging manifestations, and also some of the biomechanics that underlie injury of bone in general. Stress injury of bone is a very important disorder, and we're seeing it more and more frequently. And my objectives in this talk are to define what a stress injury is, to talk about the different concepts of repetitive trauma and microdamage that lead to stress injury of bone. We'll talk a little bit about how bone repairs itself. I will define the differences for you between insufficiency and fatigue fractures, the biomechanical differences between cancellous and cortical bone, and then we'll focus on imaging, and I'll present an MR imaging classification that is widely used. So let's get started. First of all, when we talk about fractures, we divide them into three basic types. We have traumatic fractures in which a single episode of injury, usually a high-load injury, results in failure of the bone. We have pathologic fractures where a focal lesion, usually a lytic lesion like a metastasis, weakens the bone and it breaks after minor trauma or no trauma at all. In stress fractures, the injury is repetitive, and that is the key. It is repeated low-level injuries that result in bone failure, and they're subdivided into two types: fatigue, where the bone is normal, and insufficiency, where there's some problem with the underlying bone, usually osteoporosis. Now, when we talk about biomechanics of bone, or any material for that matter, any engineer in the audience is going to be familiar with this curve. It's called a stress-strain curve, and it shows the parameters that describe the strength of any material. It shows us how much load the material can sustain before it fails, and it shows us how much deformation, also called strain, the material can sustain. So materials can fail because they are deformed or because they're loaded. And we get a curve like this that shows you the failure points of a particular material. And bone is a very, very versatile material. It can tolerate significant amounts of distortion in its shape, as well as loading of the material before it actually breaks. Now, as you look at stress injuries in the United States right now, about 15 to 20% of all the fractures we see are actually caused by repetitive injury. And this is for many reasons. There's a big increase in people participating in sports, and that includes many older people who are participating actively in physical activities, and their bone is no longer as strong as it was when they were young. In a stress injury, you have repeated episodes of micro trauma that result in weakening of the bone, and the bone is unable to heal itself, and you eventually wind up actually lowering the failure point of the bone. We refer to this as microdamage. So microdamage takes place in the scale under 1 millimeter, in the range of 100 to 500 microns. And it takes the form of microcracks in the bone that are resorbed by your body as part of the healing process. And if this microdamage accumulates, in its initial phases we'll see mild edema, subtle cracking starting to take place at the subchondral bone, but if you don't rest, the injury will wind up completing itself and developing a real fracture. So as we talk about bone and different materials in imaging, we tend to focus on them at a macroscopic scale. But much of the damage in stress injury when it starts takes place at this microscopic scale of the osteon and of the trabeculae. Failure obviously also takes place at the nanoscale in the collagen fibers themselves, but these really do not at this time have any in vivo imaging correlate that we can use. Here are some electron microscopy images, obviously done in vitro, showing this type of microcracking that's taking place within the bone. And our question really becomes, when should we call this a fracture? Because this type of cracking is going to occur at all of the different length scales that I just mentioned. In clinical practice, we are going to focus on the damage only when it becomes macroscopic. Now, how does your body heal itself from all of this micro damage that we accumulate through our activities of daily living? There's a very well-organized cellular unit that's referred to as the basic multicellular unit, which is the coordinated action of osteoclasts that resorb the bone, shown here in red, and osteoblasts, shown here in blue, that repair that damage. And you can see that this has a phase of resorption and a phase of filling in. So this remodeling starts by the activation of the osteoclasts when they sense micro damage, and they resorb the areas that are abnormal. So that bone is weakened during this time. Once the bone is resorbed, the osteoclasts become non-functional. The osteoblasts get to work and start to repair, forming bone and then mineralizing it and then becoming quiescent. And it's important for us to understand that this entire remodeling period is much slower than many people think. It takes an average of at least 3 to 4 months before a full cycle is completed. Patients' symptoms are maximal during the resorption and reversal phases. So what will happen is that their pain may go away after the first 4 to 6 weeks. They feel like they can get back to activity, but the bone is still very weak and can fail more easily. So it's important to understand that the cycle is slower than most people appreciate. Now, at a histologic level, this unit is organized in the shape of a cone, where we have the osteoclasts at the leading edge, at the wide part, resorbing bone, and then behind them a tail of the osteoblastic activity that is making bone, as you see in the example here. In cortical bone, we don't understand the pathways in cancellous bone as well as we do in cortical bone. Now, we've talked about how repetitive injury results in a failure of bone because this microdamage now moves the failure point down lower. The bone is weakened by all of these little cracks that take place. Now, microdamage happens to your body every single day, and according to Wolff's law, your body will adapt to it if it happens slowly enough. And Wolff's law has never been precisely stated, but the basic concept is that the bone in a healthy living system will adapt to the loads under which it is placed. So what will happen is that the physiologic response of osteoclastic activity is balanced by osteoblastic activity. And we can see this in daily practice. Here in a runner, the marked thickening of the anterior tibial cortex. Here in a patient with a congenitally long second toe that's taking most of their weight, that the cortex is much thicker. And this is a normal physiologic response to stress. When you have excess stress, as we have here in a baseball pitcher who is using their arm to throw balls at velocities that are far beyond normal capability, you can see the marked thickening of the humeral cortex that has taken place in this pitcher. This is actually referred to as femoralization because the cortex becomes as thick as it does in the femur. So we can think of Wolff's law as saying that bone is a dynamic tissue and it adapts to loading, thickening with excess activity and thinning in the presence of decreased activity. Another example in a patient with a unilateral pars interarticularis defect, and you can see the hypertrophy of the contralateral posterior arch as it takes increased load, and you can see that the bone becomes thicker. So this is a pathologic process, and again our body, because it's slow, has adapted to it. The essence of a stress fracture is that there is some imbalance between the bone resorption and bone formation. In this patient, who is an avid runner, we can see a fracture developing within the talus with a clear line, and then other areas of patchy edema, probably microdamage in these areas resulting in some edema, but no frank fracture line is visible in these particular regions. One good example for us to keep in mind for how an imbalance might be created are patients who are taking bisphosphonate drugs. And we now know that in a small group of patients, after long-term treatment with bisphosphonates, that they develop unusual femoral fractures. And what happens with bisphosphonates is that this entire cycle of bone resorption and bone repair breaks down because we have death of the osteoclasts and we don't have any signaling taking place from the osteoblasts. So there's a shutdown and microdamage is accumulated and the bone will fail. The failure is rather characteristic. It is a short transverse fracture line seen at the proximal lateral femoral diaphysis and may manifest in its early phases as just a small region of heaping up of periosteal new bone formation, the formation of what is called a beak in the cortex of the femur. Here's an example of such a beak in the femur, perhaps a subtle lucency visible within it, mild uptake on the bone scan, and yet after very little trauma, this patient sustained a complete fracture. Now, some patients may not have symptoms related to it, but most of them do have some pain. The presence of pain, particularly if you see a black line in the region or resorption cavities with cortical lysis in that area, are associated with an increased risk of symptoms and a high fracture risk. Now let's turn to stress fractures in general. These are divided into two types. Insufficiency fractures are generally seen in older patients where the bone is weakened due to some disorder that decreases its repair capacity, like I just showed with bisphosphonates, or something that interferes with its strength and elastic resistance. Fatigue fractures are generally seen in younger patients, and it is from repetitive stress on normal bone. In general, insufficiency fractures favor cancellous bone, and fatigue fractures favor cortical bone. But we have considerable overlap in these two categories. We have older patients who do a lot of vigorous exercise, and we have younger patients who may have some disorder of their bone due to a variety of conditions that lead to weakening, one of the most common of which is the female athlete triad, where high-performance female athletes will develop an eating disorder, and with the low body weight, an eating disorder, they will frequently have hormonal imbalances leading to amenorrhea and become osteoporotic. And here we see such a patient. This is a young female who is a runner with a fracture of the calcaneus, additional areas of cortical injury involving the distal tibia, and then some more subtle areas of edema seen in the talus. So I'll talk about insufficiency and fatigue independently, but there's actually considerable overlap in these two groups. Insufficiency fractures tend to involve the axial skeleton and the lower extremity. They are uncommon in the upper extremity, and the common causes I have listed here with the activities that are related to them. There are a number of different disorders that are associated with insufficiency fractures. The three that are best known are osteoporosis, previous bone irradiation, and osteomalacia, but there are a host of other disorders that can lead to insufficiency injury, and here in a young patient with an insufficiency fracture of the femoral head, the underlying disorder was a rare condition, in this case osteogenesis imperfecta. So there are a number of different disorders that we need to keep in mind. And because there are so many diseases associated with insufficiency fractures, the history is often confusing or unhelpful because they may have a coexistent other condition that actually delays the diagnosis. When people have a known disease, we tend to ascribe symptoms to that particular disease. So since these patients are often elderly and have many other medical problems, the diagnosis of insufficiency injury may be missed for some period of time. Similarly, patients who have a history of malignancy who develop insufficiency injury of their bone for a number of reasons due to poor diet, prior irradiation, etc., we have a tendency to try to ascribe their symptoms to that underlying malignancy. So these tend to be diagnosed relatively late and are frequently overlooked in their early phase. Now, as imagers, we tend to rely on bone mineral density measurements as our hallmark for deciding when the bone is insufficient. But this is actually not a complete picture of the strength of the bone. In fact, when you look at patients who have fragility fractures, the variance that's caused by quantitative measurements really only accounts for about 50 to 60% of the variance. And we have to think of bone strength as a composite, not just of density, but of many other features of the bone, such as the quality of the tissue, the quality of the collagen, how well that mineralization is organized, and the architecture of the cortex and trabeculae in that bone. So measuring density alone is really not enough. Bone may be dense and yet not really function well. As we look at those curves that I showed you earlier, let's say we look at a bone that is in its optimum load with a failure point that's fairly high, we can see that bone, whether it's hypo or hypermineralized, has a worse failure point and tends to fail more early. So bone that's hypermineralized actually becomes more brittle. It's easier to crack, and so being dense doesn't necessarily make the bone stronger. Here's an example here where we can see in a patient with Paget disease where the bone tends to be very thick and very, very dense, and if you did a density measurement it would be increased compared to normal, and yet we all know that this type of bone is actually softer than normal bone and has a tendency to break. And here we see the typical fracture line associated with Paget's disease involving the convex surface of the bone. Let's turn now to osteoporosis. Osteoporosis is, first of all, a non-uniform diagnosis. It results in bone loss, but that bone loss is preferentially in cancellous bone rather than in cortical bone. And here we can look at some specimens taken from an article by Dr. Ritchie from University of Berkeley, and you can see that as you compare these specimens, that the bone in the older specimen is thinned and that the voids have become considerably larger with loss of some of the secondary struts that are present in the younger bone. This is a change in the architecture of the bone, and similarly we can see in these two specimens, normal and osteoporosis from stress shielding from a hip arthroplasty, that the architecture of the bone is very, very different. And we know this intuitively. We know that these toothpicks can be constructed in a fashion that makes them extremely strong, like this tower that can support up to 1 kilogram of weight. But at this point, our imaging availabilities for how to measure architecture are rather limited. This is an in vitro analysis of microarchitecture of bone using computed tomography, and these are some images from the group at NYU given to me by Dr. Chang, showing the use of high-resolution MR for looking at microarchitecture. You can see the difference between the control bone and this high-field image of the distal femur in a patient with a fragility fracture. But at this point, these microarchitectural measurements are really a research tool and not used in clinical practice, but they're going to play an important role in helping us predict which patients are going to fracture. Now, the reason that this architecture becomes important is that if you look at bone, you can see that the way that it is organized is designed to minimize the length of these slender columns. By slender columns, I'm referring to the main compressive trabeculae that are found in all bones along the axis of major weight bearing. But they are supported by cross struts, and these cross struts, the trabecular bone, are really important for bone strength, and they basically act to create a shorter length of an unsupported column. And we know this from looking at a stool, for example, that you can put more weight on a stool that has these types of cross struts. So when you have a bone that experiences some loading and those cross struts fail, the ability of the structure, whether it be a stool or a bone, to hold weight goes down quite markedly. One way to study this is to use finite element analysis, which is a method where we can look at a material and describe it in terms of consisting of a number of smaller elements. So this is really a research type of tool, but you can do an analysis on a bone, for example, the femur here shown in normal and in porosis, showing the incredible increase in loading that it's taking place along the neck in somebody because of all of the voids and loss of these secondary trabeculae. Another focus of research right now is the supporting role of marrow fat in also helping to support bone strength. So as we look at all of these materials, it's important for us to understand how it is that the bone will fail. And we can look at the basic mechanisms by which bone can fail, and we divide them into uniaxial forces, where the force is in one direction, compression, where the bone is shortened, tension, where the bone is lengthened or shear, or we have multiaxial, more complex forces such as bending and rotation and off-axis shear that can lead to bony failure. So these may of course be combined, but this is the simple mechanisms that I will be referring to for the rest of this lecture. And we need to remember that this is rather simplistic because it assumes a homogeneous material that has the same properties in all directions, and we know that that's not true for bone. Bone shows anisotropy, and it behaves differently depending upon the direction in which it is loaded. So it is not a uniform material like we see in the lab. But we're going to stick to just the simple concepts of talking about compression and tension, etc., and to simplify this discussion. Now, one way to think about osteoporosis and weakening of bone is to think about the loss of these internal struts as equivalent to what happens when you have a box and you lose the internal supports. We all know that these internal supports lead to quite a bit of increased strength in terms of supporting the cortex, and that when you have these voids that take place in the bone, that bone is more likely to fail. And it will fail easily with compression. It will fail easily with tension and shear. It is particularly vulnerable to shearing forces where compression is applied at an angle to the bone. And as that happens, we start to get further failure of the transverse trabeculae, and then ultimate failure of the longitudinal trabeculae. Now, when you get fractures in cancellous bone due to these mechanisms, the failure is not cortical, and it's cancellous. And why that's important to us as radiologists is that the periosteum is not irritated as part of a cancellous fracture. So you don't expect to see periostitis. Early on we see very little. As the bone starts to respond, you will see some sclerosis, and the fracture line, both the band of sclerosis and the fracture line shown here on the MR, run perpendicular across the major axis of the weight-bearing trabeculae. On MR, we can also see during this time bone marrow edema. That sclerosis is difficult to appreciate on x-rays and difficult to appreciate even on computed tomography. Here we see an example of some subtle sclerosis crossing the major weight-bearing trabeculae of the calcaneus, some patchy, irregular edema shown here on the T1, and very, very intense edema in the surrounding tissues and in the bone shown on MR. So CT is not particularly sensitive until the osteoblastic phase starts and the bone starts to heal. Here we see another example, conventional radiograph early in the course of an insufficiency fracture. Looks very normal. The MR at the same time shows a fracture starting to develop perpendicular to the main weight-bearing trabeculae, band-like on T1, edema on T2. Notice that the edema may mask the fracture line itself. When you're looking for the fracture, a non-fat saturated sequence such as T1 or a non-fat sat proton density or gradient echo type of sequence is often more helpful. Here's the x-ray later on, and now the fracture line is manifest. This is taken about 3 weeks later, and you can see this band of sclerosis. Again, notice that the cortex is intact and there is no periostitis. So periostitis is not a very helpful feature when you are looking at insufficiency fractures. These are quite common in patients even with very low levels of activity. We see them quite frequently in the calcaneus, simply from walking, the deformity that takes place from repetitive heel strike, leading to failure of the bone, again, usually paralleling the posterior tuberosity and perpendicular to the main weight-bearing trabeculae. And we do fairly well at diagnosing these on radiographs. Where we do quite poorly is in the axial skeleton. Here we have a patient who has insufficiency fractures of the sacrum. This is the initial radiograph. I don't see any abnormality at this time. This is the follow-up radiograph obtained a few weeks later and the corresponding MR showing these bands of sclerosis located in the sacral ala. They're frequently bilateral, as we see in this particular patient, but they may be unilateral as well. And on x-rays, these are challenging for us to identify because we have a lot of soft tissue, fecal material, etc. overlying the sacrum, so it may be difficult to see these. But as you look, you'll notice that as you follow these arcuate lines outward, that they thicken and become more sclerotic, and it's with comparison to the prior that the diagnosis is often more apparent. Here's another patient with these insufficiency fractures. These are quite common. We usually see them in older women, many of whom have had radiation. And this is confusing because if they have a history of malignancy and you see this intense edema in the sacrum, it's tempting to diagnose this as metastatic disease. But we want to remember the characteristic appearance, which is in the periphery of the sacrum with a coronally oriented degree of edema and a coronal component that may take place around S2 or 3, but that the dominant fracture lines are sagittally oriented out in the periphery of the sacral ala. And they together with the sagittally oriented alar fractures and the more transverse or coronally oriented S2 segment will produce what is known as the H sign or the Honda sign that is a hallmark of this particular type of fracture. Here's a patient in whom we see one that is unilateral. You can see this band-like sagittal fracture line. Notice that on this sequence, which is more fluid sensitive but not fat suppressed, that the line is actually challenging to identify. So you have to be very cognizant and careful and look at all of your imaging sequences. There's another picture of the fracture. Notice that the soft tissues are preserved and there is no periostitis, and the diagnosis is quite apparent on the CT examination, showing you this band of sclerosis involving the left sacral ala. We also see insufficiency fractures frequently in subchondral bone. And what happens here in the subchondral bone is that there is osteoporosis that takes place as a result of many factors, in this example related to disuse. And I illustrate this because with disuse, the demineralization is very rapid, and it tends to be preferentially in the subchondral bone plates as well as around the regions of the original Physeal plates. And so you see this rapid type of disuse osteopenia. But look at what's happening to this subchondral bone plate. It is markedly weakened, and this bone is cancellous bone over here. So it's very vulnerable to failure. And let's take a look at what happens to this patient. This was a diabetic patient who has an ulcer of the foot, had an amputation. There was some osteomyelitis that developed subsequent to this, for which the amputation was performed. She comes back in and is having increasing pain. We can see the osteoporosis developing from disuse in the subchondral bone plate, but if you look carefully, look at what's happened to the head of the second metatarsal. It's got sclerosis, it's smaller, and its shape has changed. And this is an insufficiency fracture of the head of the second toe, easily overlooked because we are again focusing on the area where the amputation has taken place. But in the setting of this disuse osteopenia, this has now become the major weight-bearing bone, and you are seeing a failure. We tend to forget that insufficiency fractures can involve this type of subchondral bone. They are relatively subtle. Here's another example. The patient in May starting to have some symptoms, but the radiograph is normal. And here in June, we see this band-like sclerosis developing at the head of the second metatarsal. And these were nicely described by Martin Toriani from Mass General several years ago in an article where he outlined that these types of fractures were particularly common in women who wore high heels, which changes weight bearing and tends to overload the metatarsal heads very, very significantly. Another place that we see subchondral insufficiency fractures very commonly is around the knee. And this is often a reflection of pathology of the meniscus that allows the meniscus to extrude. And as it does so, we have overloading of the cartilage and the subchondral bone, leading to fractures that may take place on both the femoral or the tibial side. These are insufficiency injuries, and they are the result really of a failure of this entire complex of weight bearing. And this disorder can involve the cartilage as well as the bone. I illustrate with this bookcase what happens with overloading. And as you overload and deform it, the failure that takes place again is initially in those transverse struts. Now, this type of fracture that's in the subchondral bone is also transverse, but you can appreciate that it can be quite difficult to see because it abuts another low signal transverse structure, which is the subchondral bone plate itself. And you can see here that this type of sclerosis and flattening is challenging because it looks very similar to avascular necrosis. And in fact, this particular entity of failure of the subchondral bone in patients with meniscal pathology was often referred to in the past as spontaneous osteonecrosis of the knee. We now know that spontaneous osteonecrosis of the knee is neither spontaneous and nor is it primarily osteonecrosis, but that this is actually the result of an insufficiency fracture of the bone. And there is some beautiful work from Bullock and Yamamoto from New York showing the histology of this entity. They initially described spontaneous osteonecrosis, but subsequently have realized that this is an insufficiency fracture. And here we see from their article the microfracturing that is taking place and failure at the subchondral bone plate. So while this can look a lot like avascular necrosis when it's isolated to one area and there are no known risk factors, when the edema is very pronounced, you really should consider the possibility that this is an insufficiency fracture and rest the patient. You may bring them back for imaging in a 3-month follow-up and see if the changes have resolved or reversed. This happens in many parts of the body and it's gone by many names. We now know that transient osteoporosis of the hip is typically caused by an insufficiency fracture, and as we do more high resolution imaging of the hip, some of the lines and bands that were not apparent when we were doing large field of view imaging of the entire pelvis can now become manifest. So these are a common entity that you should be aware of. Let's look at some areas where insufficiency injury is less common. This is a patient who has had a reverse shoulder arthroplasty. This is an interesting design that allows the shoulder to be replaced even in the setting of a completely atrophic rotator cuff musculature, and it relies instead on the deltoid being the main mover of the arm. And here we see on the follow-up that the prosthesis looks fine, but look at the orientation now at the acromion. It is low-lying and downsloping, and because of the overloading by the deltoid on the acromion, we have developed an insufficiency fracture, a well-recognized complication of the change in weight bearing that takes place as a result of this particular prosthesis. Here's another patient with a prosthesis. The immediate post-operative, everything looks fine. There's some soft tissue gas from the surgery. She comes back in a few months later and is having pain. The component looks fine, but look what's happened now at the ischium, where we have developed an inferior pubic ramus fracture. So the patient is very happy with the results of their arthroplasty. She's walking much more. She's in a physical rehabilitation program, but as a result, she now has developed a fracture. And if you look carefully, there's another fracture, more subtle, developing in the superior pubic ramus in the absence of any particular trauma other than remobilization. This is a patient with rheumatoid arthritis, and she's come in, and you can see here that she has some soft tissue fullness and erosion related to her disease. At the calcaneus, some thickening of the proximal Achilles tendon, but I draw your attention to the insufficiency fracture in her tibia, manifest with this band of sclerosis. She also has a fracture starting here in her fibula. This was more of a conventional traumatic fracture, which is oblique and cortically oriented after a very minor trauma. So you can see that in a patient with an underlying disease, that things can get very, very complicated because your eye is distracted by all of the other features, and it's tempting to ascribe all of the changes related to rheumatoid arthritis. So it's easy to overlook insufficiency fractures when patients have underlying diseases. This is another patient with rheumatoid arthritis with multiple insufficiency fractures involving her iliac bone, both sides of her sacrum, and unfortunately these were not diagnosed for quite a long time, and this is after several months of pain. We can see that the right sacroiliac joint fracture is actually displaced. There's some soft tissue fullness in the iliacus related to it, and we have developed gas inside the bone. So intraosseous gas develops in chronic insufficiency fractures, presumably related to areas where the bone has become necrotic. It does not indicate that there is infection in the bone. So be aware of this. You will see this in the vertebra quite frequently in insufficiency fractures, where you see a vacuum phenomena in the broken vertebral body, but it is a finding in chronic insufficiency injuries. And here we can see the displaced sacroiliac joint and the number of fractures that's present in this poor patient. Diabetes, similarly, is a disease in which we see a large number of fractures. In the diabetic patient, these fractures can coexist with neuroarthropathy, which makes them more challenging to diagnose, and the patients may not present early in the course of their disease because they are insensate. So since they don't tend to have as much pain, the fractures may be diagnosed late. This patient did have some symptoms at this time. The X-ray shows mild osteoarthrosis with joint space loss. The fracturing is not apparent, and here on the follow-up we can see the fragmentation that's taken place in the bone, and here on the MR, subchondral fracturing that's taking place, and malalignment and intense edema related to insufficiency. So diabetics, when they do develop a fracture, do have a worse prognosis because they tend to collapse and displace. Here's a patient who's had radiation developing fractures, and radiation is another important thing to keep in mind because it reduces not just bone density, but it reduces many other parameters in the bone, including its ductility and its fracture resistance, and this is a progressive phenomena that is related to radiation dose. But again, we tend to overlook these because we're always worried about an underlying malignancy. Now, the place where fractures are really a problem from insufficiency is around the area of the femoral neck. These can be subtle and challenging to diagnose on radiographs. In this patient who's very osteopenic, the fracture line is pretty visible, but in some cases, especially early, they are very difficult to diagnose. Now remember that in this location, that fractures, whether they're caused from trauma or fatigue or insufficiency, they all have a rather similar appearance. They tend to involve the inner aspect of the femoral neck, and they tend to, again, cross those compressive trabeculae that I mentioned to you earlier. Excuse me. So in the femur, our primary compressive trabeculae run along the medial side. We have a more transversely oriented band of secondary trabeculae that are tensile. These can also fail, but less commonly. The primary failure we're going to see is across the compressive band. This patient is also starting to show some tensile band failure, and tensile band failure has a much worse prognosis, much more likely to displace, and so if you see disease starting on the tensile side, these patients will typically be managed surgically, whereas the compressive-sided abnormalities, when they're mild and subtle, can be managed with rest. Now, the reason that we have so much failure taking place at this medial neck is that the anatomy here is very interesting. We have a structure called the Calcar femorale, which is a strut of cortical bone near the lesser trochanter that transfers weight from the medial femoral neck into the medial femoral shaft. And you can see that this region here where the calcar is present is the site of very, very intense loading of the bone. And that's why we see so many fractures in this area, not just from insufficiency where the compressive trabeculae are failing, but also from fatigue because of the incredible loads that are transmitted through this particular region. So with this discussion of the calcar, I'd like to move now into talking about the fatigue fractures. Fatigue fractures, like insufficiency fractures, predominate in the lower extremity, but there are a few that take place in the upper extremity as well, and they are often related to particular sports, and they tend to be seen in younger patients who have open physes. So let's look at some of these different types of fatigue fractures that we encounter commonly in our practice. But remember, again, the majority of these are going to involve the lower extremity, and by far the number one activity that's associated with a fatigue injury is running. I'll start first by showing you some upper extremity fatigue injuries, even though they are less common. Remember, these are often going to be seen in your more juvenile patients where the physes are still open. This is a young adult, late teenager. The physes had almost closed, and this is a picture, and this is an insufficiency fracture involving the olecranon. Here we can see the fracture line starting where the site of physeal closure is not yet ultimately completed. So we can see this from American baseball. This is an adolescent who is a gymnast showing bilateral fatigue injury involving the physis of the radius, and in these young gymnasts, the radius is now the dominant weight-bearing bone. In these patients, they're taking their body weight repetitively across this area. And here again in a baseball picture at the humerus, where we have widening of the physis on the right side. And this is the zone of vulnerability that we see in children, is around the area of their physeal plate. So they will develop Salter 1 stress fractures through the physeal plate that can be challenging to diagnose on imaging until there is some widening or bone resorption that has taken place. Now, around the physeal plate, you may see these areas of chondral hypertrophy, and these have been described as FOPE zones, or FOPE standing for focal periphyseal edema. And you can see these in very, very active children, where around the area of the physis you will get some increased signal and some physeal widening. It is focal. And the clinical significance of this type of FOPE zone is still uncertain. It's probably associated with symptoms, but we do see this just in adolescents who are having minor pain, and it's difficult really to know what to call these. I don't call these a fracture when they are small and focal, but they're certainly along that spectrum of overuse injury, and we do recommend that the patients rest when you have these types of FOPE zones develop. But we have much to learn about these still. Here's what they look like in a blow-up. You can see some chondral displacement that's taken place focally at the physeal plate, surrounded with edema in a child who's very physically active, who also has Osgood-Schlatter edema at their tibia and some infrapatellar bursitis. So the immature skeleton really behaves differently than the adult skeleton. Children also participate in a lot of sports and activities, and so we want to remember that their physeal plates are particularly vulnerable. And another thing that we need to remember, their bone may fail as a result of bending, and this bending takes place because the pediatric skeleton has a capacity to bow. Adult bone, which is more brittle than pediatric bone, will tend to crack and break. But the immature skeleton, the bone is what we call ductile. It is able to deform without failing, and in fact there's a peculiar zone in here that's called a necking area, where a permanent bowing deformity can develop without a fracture. And here we illustrate an example. There's a fracture, obviously, of the distal radius, but notice the bowing deformity of the ulna. And it's worth noting this because sometimes the bowing, when it's severe, can block an accurate anatomic reduction of the other bone. So we tend to see this in very thin bones like the clavicle or the fibula or the ulna, this necking type of phenomena in the immature skeleton. So let's turn now back to adults and look at fatigue fractures. What's the history? Typically the patient is participating in some sort of a physical activity, and the time when fractures are going to develop is if the activity is new or if they start a different sport. They change how they're doing that sport. Perhaps they increase the distance that they're running, or they change terrain, start running on concrete rather than on grass. But some sort of a new or different activity will result in fatigue fracture. And the most common location by far is in the shaft of the second metatarsal, followed by the third metatarsal. Now, fatigue fractures, unlike the insufficiency fractures that I showed you earlier, start in cortical bone. And because of that, periostitis tends to be an early feature, which is helpful for us as radiologists. Now, cortical bone and cancellous bone show quite different properties. And as you look at our bone, you can see that the cancellous or lattice bone here makes up the majority of the subchondral bone plate. Cortical bone is more concentrated in the shafts of the bone. There is, of course, a thin shell of cortical bone around the entire perimeter, but it's going to be thickest in the shaft of the bone. It is much stronger in terms of its ability to handle load. So you can put a lot more load on a cortical bone than you can on cancellous bone, but it is stiffer. It is not able to deform as much. So if it's bent, it doesn't tolerate the bending because it doesn't have the capacity to change its shape greatly. So the two together make for an excellent construct. One area tolerating deformation, the other area tolerating load. So these biomechanical properties are quite different, and the fatigue injuries that we're going to talk about really predominate in this cortical bone segment. The main features of cortical bone that make it different than cancellous bone is that it's very different in terms of its tissue porosity. By porosity, I'm talking about spaces in it. There's very little empty space inside cortical bone. It's tightly packed with osteons that are organized in these longitudinal bundles, whereas there's a lot more empty space filled with marrow elements and fat in the cancellous bone, making it a much more porous structure, much more loose and less dense, less heavy than cortical bone. So now we're going to focus in on the cortical bone. Cortical bone is best thought of biomechanically as behaving like a hollow cylinder. A hollow cylinder is a great way to use a small amount of material, right? You don't have to have a lot of material in order to create a cylinder, so you get great strength without a lot of weight. Here we can see a bird's ulna with this form of a hollow cylinder, and we all know that cardboard tubing like this inner part from a roll of a paper towel is very, very strong and yet has very little weight. So in a world where getting substrate is difficult, you have to go hunt for it, you have to go find it, you have to eat. Finding substrate was challenging. You want to use as little substrate to get as much strength as possible. So this is a design that is widely found throughout biology. And if you think about it like bamboo, you can understand that the structure of bamboo and the structure of bone are extremely similar. It's a very common design strategy to use a hollow cylinder. So when you look at a hollow cylinder, as the wall gets thicker, it becomes stronger, given an equal diameter. And for a given wall thickness, as it becomes bigger, it becomes stronger. And so all of these are going to require increasing substrate to make that wall thicker or to gain diameter. Now, when you think about the bone and you think about how strong it is and how much load it can take, why does it fail? Well, it fails because it doesn't tolerate bending very well. Bending happens to your bone when it's loaded, whether it's loaded because you put weight on it or because of internal forces. And the main bending forces that take place internally are due to the pull of muscles. So muscles will attach to bones via a tendon and an emphasis, and as they contract, that bone is going to bend. Now, bending related to weight bearing and bending related to muscle are finely balanced. So as you run, for example, on your tibia, if you didn't have any muscles, the bending direction is convex anteriorly. The pull of the calf musculature reverses that, and now you are concave anteriorly. And when these two are well balanced, you wind up having very little bending moment in the bone, and things go quite well. If things are unbalanced between the weight that's being taken and the muscle, you'll wind up with problems, and you will wind up with some sort of a fatigue fracture in the bone. And we see this often in athletes. What happens is if you start a sports program, your muscle will hypertrophy quickly. Muscle will respond to increased activity at a much faster rate than the bone does. So when you look at the over-muscled athlete, as we have in this patient, those are patients that are more at risk actually of breaking their bone when they start a new activity. And this is a patient who's starting to develop an intracortical incomplete fracture involving their posterior femur. This is actually a professional athlete that we deal with, and he had changed his training program quite drastically and to make up for an injury that he had sustained at his ankle, and he wound up developing a fracture. But it's this imbalance of muscle to loading is worth remembering. Now, when the bone is bent, we start to see crack initiation. And this is the same as if I were to give you a piece of bamboo and ask you to break it, what are you going to do? You're going to bend it. And you'll start to see cracking developing on the surface. Now, the exact direction of those cracks varies. With tension, the crack is perpendicular to the angle of the force. In compression, the cracks are more angulated. And you can just go home and take a bamboo or a stick or any paper tube and bend it, and you will see that these crack directions are going to be different on the convex side where it breaks across, and on the concave side where you'll get a more angulated type of fracture. A similar phenomena happens in your bone. Now, compressive cracking takes place, and it's certainly important. We can see it here in this woman whose husband made her start a running program to lose weight. She wasn't very happy about it. She was complaining of pain, and he kept making her run, and she has developed this obliquely oriented fracture around the Calcar area that I mentioned to you earlier, where a lot of compression is taking place. Here's the oblique orientation of that fracture line. It's certainly a very, very important mechanism. We all understand that, but we also need to understand that we can see breaking due to tension. So on the surface of the bone, that is the convex side where there is increased tension, we have compression on this side and tension here, we wind up debonding the bone, we get transverse cracking, and we wind up with these exposed osteons. Now, this is a runner, and we have multiple of these striations. That is what we see with tensile microcracking taking place in the bone. And these are difficult for us because not all of these patients are going to have symptoms related to it. So let's take a look at what happens to somebody who starts to develop this type of a problem. You start to get overuse and microdamage where we don't see anything. If you stop and let the bone heal, everything is fine. But if you keep overdoing it, you will wind up actually starting to develop a crack that's now becoming macroscopic in the bone, where we're going to wind up calling it a fracture. Let's look at some of the grading systems that we use to try to describe these injuries. And none of these grading systems are perfect. And the reason that none of them are perfect is that stress injury of bone is a graduated phenomena. There's not a clear-cut step between all of these grades. So we want to remember that while this is a convenience, it's not perfect. The concepts are important. Early in the stage of a fatigue injury, as the surface cracking starts to take place, we will see periosteal edema on MR. Later on, the edema is visible only on the T2 weighted images, but the T1 remains normal. As that edema becomes more extensive, we will see changes on both T1 and T2 weighted sequences. With more advanced disease, you will see changes in the cortex, taking the form of lucencies, resorption cavities, and intracortical signal changes. This is the Fredrickson grading system. It's got 2 grades for grade 4, one for lucencies and one for frank cracks. A variation of it that's frequently used in radiology is the Beck classification. It's similar, except it puts the lucencies at grade 3, and then for grade 4 wants a frank fracture line that's visible on all MR sequences. They're very similar otherwise. Whichever one you use is fine, and I'll illustrate these so that you understand the concepts of what happens early and what happens late. The first thing that's going to happen is periostitis, and it is easy to overlook on MR imaging. Here on a T2 weighted sequence, we can see periostitis along the medial femur in an avid athlete. He also has a low-grade muscle strain, which we're not going to focus on right now. We're going to focus just on this periosteal new bone formation. There are no marrow signal abnormalities at this time, and that's why it's relatively easy to overlook these changes. Here we have another example of grade 1. Notice how subtle it is, and there is no way we would have seen this except for the fact that we had a corresponding bone scan showing this very, very subtle area of uptake. So MR, though it can show changes on grade 1, the changes are quite subtle and they are easily overlooked. They are also easily overlooked on scintigraphy. This is another example. We have a little bit of uptake on the bone scan. This is the initial MR. We have periostitis, and the problem we have here is that it looks a lot like vessels. So your eye needs to understand that this is running across multiple slices. It's not just a vessel because it is linearly oriented, seen on several sequential slices. Here on the follow-up examination, you can see that all of that material is now gone away. He's now pain-free after 2 months, and this is the corresponding radiograph at the 2-month follow-up with a little bit of periostitis and thickening that developed in the area of very low-grade stress injury, really no significant marrow abnormalities to be seen. Obviously, radiographs at this early stage are also insensitive, and it's been shown that it takes an average of 10 to 14 days for any periostitis to become evident after a stress injury starts to develop. So here's an early stage with some mild fuzzy periostitis, and here on the follow-up you can see that this is done several weeks later that the periostitis is solidified and there is some sclerosis in the bone related to this stress injury. Now, when these cracks start to form, if you look at cracks in a uniform material, the cracks is just going to continue going across the bone. But bone is not uniform, it's a composite, and it consists of all of these longitudinally oriented osteons, and so the crack is deflected by the osteons. This is an important concept for us about why fracturing will often stay within the cortex and lead to the resorption cavities that I'm going to show you in a few minutes. So crack pathways will get deflected. They get deflected longitudinally. They get deflected within the osteon, between the lamellae, and they get deflected between osteons and turn upwards. This is incredibly important for you to realize that when you see stress injury, it does not easily get across the bone. It is going to propagate inside the bone for some time, and that you need to be aware of that and look for this type of longitudinal intracortical resorption in a stress injury. So again, the stress deflection, one of the reasons that it happens is because of a zone that is known as a cement line, and those are seen at the perimeter of osteons. It's a region that is collagen poor. It's extremely thin, shown here on this histologic specimen, and that is the zone at which these cracks become deflected, is at the cement lines, and so the fracture line that starts goes around the osteons in the transverse plane, and it goes longitudinally between the osteons in the long axis of the bone. Now, what does that mean to us? As imagers, it means that rather than the fracture going across the bone, you are going to start to see resorption cavities taking place in the bone, as we see in this example. This is a higher grade of stress injury. We have a lot of edema surrounding the bone. We also have a lot of periosteal new bone formation that's taken place. So this type of crack deflection results in resorption cavities, and here we see an example where we have an injury developing with some cortical thickening, periostitis, and edema. He does not rest. This is a professional athlete who continues his activities, and because of all of that crack deflection, we're now getting resorption in the cortex and the beginnings of a more advanced type of a stress injury. So you want to look for this. Here's another example shown on a radiograph. Again, the fracture does not go across. It is deflected by osteons and moves into a longitudinal pattern. And here we can see after rest that there is repair, that those lucencies have all filled in, that we've had osteoblastic activity, and we're left with a markedly thickened cortex, a healthy looking cortex compared to this, which will progress and fail. This is very weak bone, and we want to diagnose this earlier. These are challenging to see. Here you can see some intracortical resorption on the MR. It is subtle, shown here at a different window, but I really don't appreciate it well on the radiographs. It's hard to see this type of stress resorption in a thin, these thin areas of resorption in somebody with a very, very thick kind of bone. But you want to look for these lucencies in bone because they increase its vulnerability. I already showed you an example of these intracortical striations. Here's another patient who's a runner with a very thick cortex with these little intracortical striations. These are what is responsible for the shin splints appearance that we see on scintigraphy, where you get a long area of uptake. It is an early stress injury in the bone. They may take the form of little lucencies. Sometimes they can look more rounded. And we have a lot of questions about these because even though they have low-grade scintigraphic uptake, they are often not very symptomatic. They may not complete. Athletes don't want to stop running because of these things, and we're not really sure when to call them a fracture. Now, I worry more about these when there's only one or two of them. Here we see an example where there are only a few. When you have a lot, your load is being distributed over a great area. When there's only a few of them, you have an area now that acts as a stress riser. So a few of these are, in my opinion, much worse than having multiple ones. And these are the ones where I encourage the patients to rest because they have a focal stress riser in their bone. Now, what does a stress riser mean? A stress riser is a place where there is a focal cortical defect, and it significantly weakens the bone and acts as a nidus for a fracture to take place. This was a patient who had an osteochondroma removed, comes back in. We have some postoperative fluid and edema, but he's having quite a bit of pain in this particular area. There's some periosteal elevation you can see around the region with periostitis, and then here we can see the beginnings in the same patient of an early fracture line starting to propagate from this region. So when you have just a few of these lucencies, these are much more at risk for progressing, and so when there's only one, this is the time that some people will use the term a unicortical fracture. Others will call this the dreaded black line sign, but the solitary line is definitely more of a problem. And yet this patient here, you can see that after rest, his symptoms have resolved. The line is still visible here and has not yet fully healed. And so again, we have to remind patients that they need to rest longer and let this dreaded black line fill in so that they don't go on and complete. So in summary, you're going to see these. They are controversial how to manage these patients. If there are multiple, they are partial thickness. You don't have a focal abnormality on scintigraphy. We typically let our athletes progress with activity. When one becomes dominant, when there's more focal uptake on the bone scan, we suggest that they rest, especially if we have an MR that shows marrow edema starting to develop in the face of these, because these typically may have a little periostitis, but they don't typically have marrow edema associated with them. So the second grade is where we have marrow edema, seen only on our T2 weighted image. So this is a stage where the T1 is still normal, but you have periostitis and T2 related marrow edema in a stress injury. In a grade 3, the changes are seen on T2 and T1, and in the Beck classification, you start to see some intracortical lucencies. These are a bad sign when you start to see intracortical lucencies. So intracortical lucencies are grade 4 in Fredrickson and grade 3 in Beck. The number doesn't matter. You want to be aware of this, that you don't want to see these kinds of changes. When you start to see these kinds of changes, many of these patients will progress and start to develop a longitudinal intracortical fracture line like you have over here, and you want to look very carefully for these, though this is often easier to see this kind of a fracture line on CT than it is with MR imaging. I'll illustrate an example for you in a child that came in who's the son of one of our orthopedic surgeons, and he had this periostitis found on his femur. Here's the MR showing intense edema, but we could not see a fracture line. It's an older case, so the resolution is not as good as we would have on our newer machines and better coils. Bone scan, intense uptake in a linear fashion, and on the CT we can actually see the fracture line that's developed. So seeing intracortical lucencies and intracortical fracture lines is really a significant problem, and that patient needs to rest. Now, the whole concept of these longitudinal fractures is not well understood by radiologists, but we certainly see these in our clinical practice. Here's an example in a runner. This is known as adductor avulsion syndrome, where the adductors are constantly pulling. Again, a muscle imbalance problem with strong adductors acting on the medial femoral cortex, and you wind up seeing this longitudinal fracture. But notice that there's nothing going across the medullary bone. So you need to expand your concept of fractures and realize that they don't always go across and they don't always enter the medullary bone, but that they may be limited to the cortex, and they may be extremely long. Let's look at this patient. The radiographs show some periosteal thickening. I don't clearly see a fracture line anywhere in this particular patient. The bone scan shows an intense area of uptake. We see some subtle periostitis involving the tibia on the magnification views, but nothing like what we are seeing here on the bone scan. Here's the MR showing that intracortical fracture, intense edema along the shaft of the tibia, and on the axial images is where that fracture line becomes apparent. It doesn't really break across the medullary bone, it's intracortical. These are most common in the tibial shaft. By far, we see these in the tibia. They are actually usually located along the anterior cortex. So be aware of this pattern. They are also reported in the femur, as I just showed you. They are also reported, but they are rare in the upper extremity. But the tibia is the one bone in which we see these very, very frequently. And then the final stage that we have is where the fracture line enters the medullary space. It's very easy now, where we have intracortical extension and intramedullary extension. And once the intramedullary fracture line becomes evident, the patients are usually very symptomatic at this point. They have marrow edema, muscle edema, periostitis. But this is late. We should not be diagnosing fractures by the time they've gotten into the medullary space. We should be doing better than that and diagnosing stress injuries much earlier and having the patient rest before we have developed intramedullary extension of a fracture line. And here we can see this intramedullary extension on this beautiful specimen given to me by Dr. Murphy from Washington. So this is really a failure at this point, and our job is to diagnose before we get to this stage and to recognize some of the earlier manifestations that we have in stress injuries of bone. Here's another example of intramedullary extension. These are easy. We're all used to seeing this in our clinical practice, and nobody really has a problem with making a diagnosis at this stage. The term complete fracture refers to a fracture going all the way across the bone. We don't usually see these in the big bones. They tend to be seen only in the thin bones, that activity continues to this kind of point. So you're going to see them frequently in the small bones of the foot, or perhaps in a thin bone, like in the fibula, where a fracture has gone and completed. But remember that all the way across fractures, not that common in the thick bone, and even less common is for us to see displacement. Here's a patient with, unfortunately, one of those bisphosphonate fractures that has displaced, but in your normal patient who has repair capacity and normal sensation of pain, they will stop their activity and not get to this particular point. So again, let's go through the classification. Again, this is the Beck. You can use this or the Fredrickson. It doesn't really matter. Remember that the first phase of disease is periostitis, leading to a shin split type of appearance. The marrow space remains normal, and radiographs typically don't show very much. In a later stage, we start to see marrow edema that's only visible on T2. That corresponds to more focal uptake on scintigraphy, and periostitis is typically visible on the radiographs. More advanced disease, we start to see changes on our T1 weighted images. more obvious changes with focality and increased uptake on scintigraphy. Same findings on imaging with periostitis, and it's only in the late stages of disease that you start to see a fracture line, initially intracortical, and then later on entering the medullary space, and rarely is it complete except in the presence of a thin bone. So which one should you use? It depends on the availability of equipment, the level of commitment of the athlete. For example, in a professional sports athlete, you may go to MR imaging much earlier than you would in a normal person who has a desk job, who does some jogging on the weekend, where rest and radiographs are appropriate. Let's look at a bone, one example where I think doing early imaging makes sense. And the areas that I tend to be more aggressive about looking, obviously, is going to be around the hip at the femoral neck, because we don't want to risk displacement. But even in the foot, the navicular is a bone that is worth looking at. This is a place where we see these sagittally oriented fracture lines that start at the dorsal navicular surface, affecting the midpoint of the navicular. And why are these important? Because they have a very high rate of non-union, and similarly to the scaphoid, these have a rather vulnerable blood supply and may undergo necrosis. So here's what the fracture looks like. It starts at the dorsal surface, it is sagittally oriented, and here we can see it at the level of the talonavicular joint, which we recognize with this fried egg appearance here, that there is this longitudinal fracture coming down into the navicular bone. And the reason that we want to diagnose these early is that if you have stress injuries in the periphery of the navicular, that these may undergo necrosis, and we will develop this comma-shaped appearance and fragmentation at the lateral navicular pole. So delayed treatment of a navicular is actually a problem because of the blood supply. Here we can see a patient who has a fracture. It's quite complete already. Perhaps a little bit of density in this outer pole, and these are again at risk for developing necrosis, which is known as Müller-Weiss syndrome. And here at the follow-up, we can see that there's been more volume loss and fragmentation and development of a chronic non-union. In children, this area is vulnerable, and it leads to an osteochondrosis that we refer to as Kohler's disease. And the osteochondroses are a confusing group of conditions that include some normal variants of ossification, many stress-related injuries, whether they're reversible or irreversible, and then the advanced forms will have changes of avascular necrosis. So I think a reasonable approach to when to use advanced imaging are for those fractures where there is a high risk of non-union, the pars in athletes, the femoral neck in particular, because we don't want to see displacement. The anterior cortex of the tibia doesn't really have a non-union issue, but it does have a delayed union issue and a tendency to complete, whereas the posterior has much better blood supply from the nearby muscles. The shaft of the fifth metatarsal, the so-called Jones fracture, and the navicular. And the others that tend to heal fairly well on their own, perhaps we don't need to be so aggressive about imaging those particular conditions. The treatment for these is going to be usually conservative, avoiding whatever the inciting activity is, pain control with orthotics or simple medications, gradual return to activity. Orthotics or casting can be employed, especially in children who tend to resist rest and may require casting in order to decrease their activity level. And rarely we may do a surgical fixation. Again, tends to be for high-performance athletes or for patients who have fractures in one of the high-risk areas that I mentioned earlier. I do want to say a word about bisphosphonate fractures. At our institution, we are quite aggressive about treating these prophylactically. We know that patients who have pain, patients who have visible fracture lines, the risk of completion is extremely high, and that we will wind up doing prophylactic fixation on these individuals. So we're very aggressive about managing the patient on bisphosphonates with thigh pain. So in summary, I would like to remind you that we've looked at what the definition of a stress fracture is, concepts of microdamage and how your body repairs them and how long it takes, the difference between an insufficiency fracture where the bone is deficient and a fatigue fracture where the bone is healthy but overloaded. Remember that cancellous bone is the dominant bone that fails from insufficiency, whereas cortical bone is the bone that fails from fatigue. And we've gone through the Fredrickson and the Beck grading systems, very similar for how imagers should describe these various injuries. Once again, it's unfortunate that we were not able to come to DHAKA in person for the Bangladesh hosting of the radiology meeting.